Hello, welcome to this series of Meet the Masters for the journal VideoGIE. I am Kulwinder Dua, Professor of Medicine and Pediatrics at the Medical College of Wisconsin, and it's indeed an honor and pleasure to have today in this series one of the legends in the field of gastrointestinal endoscopy and gastroenterology, Professor Walter Hogan.
Dr. Dua, I'm honored. Perhaps you're the only one who's called me master, and that's because I pay you otherwise.
Dr. Hogan is currently the professor of medicine and radiology in the Division of Gastroenterology and Hepatology at the Medical College of Wisconsin. And I've had the honor and pleasure to be his colleague since the time I joined the medical college 23 years ago. Dr. Hogan graduated from the Medical College of Wisconsin in 1958, and he was one of the first GI fellows of this program in the early 60s. And he then went on to become the division chief at the VA Medical Center in Milwaukee, followed by then moving to the Medical College of Wisconsin Division of Gastroenterology, where he was a chief. And currently, he's still an active member of our division, and he works at this, I would not say old age, but at this time in his career when many other people of his time have already retired and gone. He has over 450 publications, including the landmark study he did on the motility of the sphincter of Oddi that led to the discovery of sphincter of Oddi dysfunction. He has been on several committees of both the AGA and the ASGE organizations, and he is one of the very few handful of people who has held the presidency position of both the AGA and ASGE. His work, his publications, his novel new discoveries, not surprisingly, makes him eligible for receiving one of the highest award that the ASGA has given so far to anybody of his caliber, and that is the Rudolf Schindler Award. So welcome, Dr. Hogan, and welcome to this Meet the Masters series of the VideoGIE journal.
Co-Winder, thank you. That was very nice of you. I feel quite honored to be in this particular interview, and particularly the kind words that you gave me. Some of the few kind words that you've ever given me, so I appreciate that.
Yeah, although I did mention that I had been with you all this time as your colleague, but you know this, that you were my mentor. And I learned a lot from you, and I'm still learning.
Well, I've been blessed to watch you mature into the person you are and the supreme endoscopist. I should be interviewing you. If I live long enough, maybe I will.
And I remember your philosophy once you told me, always train your fellows well, because one day they will be scoping you.
True.
And that's what
absolutely
I think
true.
You trained me, and I'm honored. So tell me, how did this all start? Why did you want to take up medicine? And at your time, for me, endoscopic work is the biggest attraction for me to join gastroenterology. And at your time, endoscopy was in its infancy. So how did you decide to take medicine and then branch out into the field of gastroenterology at a time when endoscopy was just in the horizon someplace?
Well, getting into medicine was something, I guess, that was preordained. My father planted the idea when I was very young that he wanted a physician in the family. And since I was the one that he picked, you sort of had that ingrained in your mind. I actually wondered between that and being an architect, believe it or not. But the further along I got in it, the more interested I got in biology and neuroscience. And so I just sort of gradually worked into it. So it wasn't a guiding light it was something that was set up for me and that I gradually got into. When I got into med school, I was concerned because I had had an accident at that time that I thought was going to impair my mobility, but the person I interviewed said, we're not interested in how you walk, we're interested in how you think, which I thought was quite a guidance. So at the time that I came to Milwaukee, and actually it was Marquette Medical School, before they changed the name, things were pretty primeval, I think. Got through school, though, and I interned here because my wife was in a class behind me. So I sort of stayed in Milwaukee at that particular time. Went through the medical residency, and I knew that wasn't exactly what I wanted. And somebody came in from Boston by the name of Conrad Sergel. Conrad had trained under Franz Engelfinger, who at that time was one of the premier teachers from the East Coast. And Conrad set up this new division of gastroenterology. I sort of liked the idea of the GI tract because it took into consideration a number of organ systems and so forth. And so I applied for his fellowship program. And since I think nobody else applied for it, I got it. Well, at that time, you'd ask about what a gastroenterologist did. There wasn't too much you could do, at least at our unit. You could either do a rigid proctoscopy, a liver biopsy, maybe get your own fluoroscopy if you're in private practice, because otherwise you would not make extra income, which was what was going on at that time. In the division here at the medical school, we had our consultations, and we also had gastric analysis, pancreatic analysis using tube drainage systems, which are now archaic. But we had a lab set up to do gastric secretory studies, do secretin studies, and we even did small bowel biopsies with a Rubin tube, blindly put down into the GI tract, waited hours for it to get where it's supposed to, if indeed it did. And that's what we sort of had. As things turned out, though, two things happened. We got the first faculty member from Yale, a fellow by the name of Dan Winship, who had trained under Howard Spiral. Dan came along and brought with him not only manometry, which he'd been taught, but endoscopy. And at that time, endoscopy was quite rudimentary, but some people did do it. And so Dan brought that along. In addition, when I went to the VA hospital, there was a gentleman who came from Havana, actually a refugee physician, who at that time was one of the premiers in Havana and who escaped Castro. In fact, the day that he left, he was being sought. And he brought with him his skills with doing endoscopy. Now, when I mentioned skills with endoscopy, this was really rudimentary. What you had a scope, the glass end of it, once you inserted it into the stomach, it would just sit there, and you'd either take advantage of whatever was going on. You couldn't clear the mucus, but this was what endoscopy was. It was semi-rigid. I know when I first started with it, the biggest thing was getting it down a patient without harm, and then trying to see what was there. It was very rudimentary, and in fact, endoscopists at that time were not well thought of, mainly because oftentimes what they saw wasn't what was there, and also there were a group of us that tended to overblow what they saw. So, for instance, if you did do endoscopy, they would put you down the end of the hallway and occasionally feed you, but otherwise they wouldn't do much else. Well, about that time, fiber optics came on board. And this way you had a flexible tube. You still couldn't really wash it or suction through it, but it was only a matter of time before that started. And we started out with the old ACMI scopes. And then, of course, the Japanese came along with Olympus and began to make tubes that not only we could intubate very well, but you could aspirate, take biopsies. And in addition to that, the biggest thing that came along that made endoscopy really a true specialty is you could have an observer attach an instrument and view the same thing you were doing. So two of you could now make an assessment. And so if you were both liars, you were in trouble, all right? But this started, and this was very rudimentary, but that's the way we started. And I can remember when we did colonoscopy, the original colonoscopy, it was a situation where it was a, I hate to say this, a two-person procedure. Somebody would handle the guidance, somebody would handle the visuals, and it was done that way because we just didn't know much better, and it was quite stiff and difficult to actually thread up the colon. Well, that changed, obviously, but I said that's the way we started out, very rudimentary. And then, of course, the other thing was that the instruments became sophisticated enough that now you could go through the stomach into the duodenum, and you could get into the sphincter of Oddi and do biliary work. And I think that's what really blossomed out and really, I think, added a dimension not only to diagnosis and therapy that the gastroenterologist had for the first time that nobody else could have. And so that sort of evolved during that period of time. It took a while to do it, but I said we managed to get on board early. I had an associate, Dr. Joe Geenan, who was in private practice, but Joe decided that he wanted to do ERCPs. And so he went to Germany, trained with Clausen, came back, and so we set up our biliary group, and that's pretty much what started it. And early on, we were somewhat of pioneers as far as what we did, our publications, and also our conferences. We had a number of postgraduate conferences, and at that time, endoscopy was really not out in the, out into the public like it was. It was mostly at the universities. It was somewhere in the practice of gastroenterology, but a lot of the gastroenterologists were not trained in it. So we had postgraduate programs in which we had really demonstrated models that they could use to try to figure out how to do colonoscopy, and even how to do ERCP. As silly as that sounds, that was the way this thing evolved. And we had postgraduate courses that actually were some of the first group to put on these postgraduate courses, which we either did in Milwaukee or Racine, Wisconsin, or occasionally we would go to the Canary Islands and put on a postgraduate program. That's something I'll tell you about someday. But that's the way it sort of evolved as far as our endoscopic training. And as it evolved, so did our interest in formalizing a lot of the training and formalizing some of the things that were associated with endoscopy, such as the what Medicare would pay for this, what you were allowed to do, were there guidelines. None of these had been established. So I got involved with the ASGE, which at that time was an age-old group that had been around for a long time and had established itself as the, if you will, the primary source for endoscopists. But it also, like a lot of us, it was run by elderly people who weren't doing the kind of endoscopy we were. So we wanted to get involved with it, get involved with their programmatic aspects, with the development of guidelines. And so I got involved with that and eventually got to be the president in the honor of running that. Now, during that time, we started with our postgraduate programs. Remember, endoscopy now was exploding in a sense. Now gastroenterologists had a technique that they could use, and it was also remunerative. And so putting on postgraduate programs, which we developed, suddenly became a hot item. And I think the the AGA began to get concerned because when we put on our postgraduate programs, we were having a capacity crowd that at least rivaled what the AGA did when they put on their postgraduate programs. And that, of course, has evolved over the years, but we put those on. We also had the opportunity, at least I did, working with Jack Venus, of developing the first program directors meeting, where we wanted people from the universities in particular to get together to have some type of standardized training for endoscopists, what they needed, what they were exposed to. And so we had that as the first meeting. In addition, just to show you how rudimentary it was, sponsored by one of the pharmaceutical firms, we developed a case of gastric ulcers, photographs of gastric ulcers, showing all types, cancers and so forth, which at that time was relatively novel and which we distributed to the membership. And I can remember I just tossed mine out of my office, but it was around a long time. So these are all sort of early on that we got involved with things. But I said the meetings we used to have with the ASGE, we had 2 a year. They were always fun. If Mel Shapiro was president, he would bring certain types of wine from California. If Jim Borland was president, we had cigars from Florida. And so not only did we think we were making headway, but we had one hell of a good time when we were with them. As far as what we did here in Milwaukee at the Medical College of Wisconsin, early on we published some of our efforts with doing a colonoscopy, and I'm embarrassed to say that one of our first articles that we published, and it was accepted, was our experience with the first 100 colonoscopies, all right? You can tell where we were with that. But subsequently, we had the ability, using our ERCP talent and our manometry, to study the biliary tract, and that turned out to be something that we spent a lot of time, did a lot of publications. I think we fairly well mapped out the physiology and some of the pathophysiology, not only clinically, but in the laboratory. I can remember the first NIH grant that I had warned us not to do this on the public, but to do it only in the lab. When it was renewed, they told me not to bother to do manometry in the lab, but start doing it on people. So you can tell how that advanced in glory and grace before God. So that, I think, was something that professionally, I was surrounded by excellent people, Joe Geenan, Jerry Dodds, our famous radiologist. And we had, I think, probably as good a biliary group as there was around the country. And it sort of evolved that way.
Yeah, that's you know, you kind of took us over a couple of, maybe 3 decades
At least.
of time, and somewhere along this course, in my fellowship, I was probably in the middle of this, and for the younger generation who are now coming into it, and even for some people who are already in it for a few years, the path you took, your sharp mind, while you're doing procedures which some people think is more like a technician, like we order a chest x-ray and they just do a chest x-ray. But you brought in that critical thinking. What would you recommend or suggest to people who are now coming into the field of GI endoscopy, who want to do academic work or want to go out and practice, in terms of the whole climate? The healthcare climate has changed, and how will this now be different had you started now?
Well, it's much more complex. In fact, it's been complex. I can remember back, I think, in 1992, when I gave an address to the AGA about what was going to be the future of gastroenterology now. Everyone was worried. All the trainees were worried because, if you remember, they started to develop PPOs, IPOs, there was a question of whether or not there were too many gastroenterologists, and so the future was quite muddled, all right? And they had manpower studies that suggested we didn't need gastroenterologists. We didn't need that many. As it turned out, that was erroneous, and actually gastroenterology and gastrointestinal endoscopy flourished from that point on up until now. It's more complex now because the private physician and the individual physician is gradually being devoured by hospital-based practices. And so some of the, if you will, the independence that we had is not there anymore. However, if you go back to our training, the thing that I think I and the people around me have tried to nurture was the fact that you're a physician, and endoscopy is a tool that you utilize with your brain. And while you can make a living, at least you have in the past, by just doing repetitive endoscopy examinations, the idea of this is to use that tool along with a thinking process to help people, to either diagnose or to treat. And so that was part of the thing that when people interviewed for fellowship, we stressed the fact that yes, there are a number of things that one can do as a gastroenterologist from the standpoint of diagnostic and therapeutic treatments. But above all, keep in your mind that this is a brain that's working and that you can do these things in the appropriate time and with the appropriate talent, but monitor that at all times. Now, it's interesting. There was, I think last month, the AGA put out a publication on update on endoscopic techniques. I'm sure you read it. Actually, it was quite sophisticated as to what one can do with an endoscope. And we're talking gastroenterologists, but of course surgeons can do that. And there are just a number of things that you can imagine now. If you date back to my experience in the 70s, one would never imagine you could do this. Well, the one thing that you got out of this is how neat this is, how extraordinary it is. And then the question is, what do you do next with this? For example, there are techniques now that handles endoscopically achalasia of the esophagus. And that would avoid a surgical operation. And at least it appears now that this technique may be validated, which is good. The only thing is, having learned that technique, how many achalasia patients will you see in practice? In fact, how many do you see in academics? So the thing about inheriting that type of talent is the fact that you can probably use that in some exclusive settings, but not out in the community. So it's a waste, in a sense. If you use this once a year, in fact, you probably shouldn't use it, as opposed to doing it a half dozen, maybe 10 times a year, where you really experience some sophistication with it. So that was my concern about all these things, because these techniques are done by experts, and they probably continue to be done by experts. But if they're going to be learned and used, there's got to be an appropriate place for them to be used. And unfortunately now, if you read the want ads about gastroenterologists wanting in practice, all of them indicate that they want the gastroenterologist to be trained in ERCP and endoscopic ultrasound. Now, if I'm going to Hoboken, New Jersey, I'm not sure how much biliary practice I'm going to have. I'm not sure how often I'm going to use it. And oftentimes, that's not only discouraging, but it sort of disrupts what you have in mind as a practice. So I think these kind of talents that you get must be tailored toward where you're going, and not to be used by everybody, because it's a waste of time. As far as the gastroenterologist and his training right now, certainly such things as colonoscopy, and upper GIs are breadwinners that have to be used in their practice, and they should be used appropriately. But Lord knows how that's going to change in the next decade. Interestingly, in that publication that I mentioned, the last article, which I thought was rather interesting, was pointed toward when you shouldn't do endoscopy. And of course, that's what we all preach. But I thought it was very appropriate with the fact that endoscopy should be used as a tool to either diagnose or treat people, and not used indiscriminately, because it gets, if you will, bad press. You're still working with people that you want to help. And like so many other things in medicine, not just endoscopy, there may be an overuse of it. I think our trainees should be indoctrinated with the fact that there is a time, a place, and a reason for doing it. And if you don't train them that way, it's a waste.
You know, at least what happens, you know, in a busy practice with all the market forces coming into play, everybody, even in academics, is pushed to produce and so on. And then comes these new techniques. You know, many of these techniques were not there when one was a fellow. They come in while you are practicing. So in that regard, you started off when endoscopy was hardly there. You picked on it, you developed on it, you became a master of it, then you published on it. And this doesn't happen like in the flow. There must be something that was driving you and bringing you to a level where something was not existent and now you're world authority.
I'm smiling.
So what's your secret on that?
My secret, good looks. That does it all the time. These were, don't forget now, these were easier times when we did this. You just mentioned right now that the time that's placed on practicing gastroenterologists and even surgeons with our limited time to see patients, the number of procedures that are expected to be done, computerized programming, doesn't leave you with as much time as it did. When we started out, I don't think I ever did anything that I really had a goal in mind. I sort of rumbled into everything I had. But we got at a time in gastroenterology when this endoscopy was just developing. It enhanced the practice. It enhanced what we could do. It enhanced our teaching. And then I was surrounded by a group of people far smarter than I was, and I could sort of attach myself to them. And we did a number of things that had to do with marrying, actually combining endoscopy, gastroenterology, radiology, so that we formed what was called the Milwaukee group. An interesting co-winder. There were no particular names. It was part of the group, so we shared. And so we had that ability, and of course, like so many other things, when you get into a research area and you can develop your results and then tell the community, tell your associates what you found, it begins to feed on itself. It sort of enhances. Well, you know, you've got the experience, and it sort of builds on itself, and I think it gives you an extra energy to do this. And plus the fact, I said I was supported by a number of extraordinarily good people that either advised, did half my work, but I was just lucky enough to be in a spot. And I think the old saying, timing is everything, probably did it, but it was easier to get along. We could, you know, we could take time, we could enjoy it. I could walk over to the radiology department and talk to our radiologist. Nowadays, you pull it up on a computer and you never talk to them. And you could interact, the discipline was good. You form friendships both in the hospital and out of the hospital with your comrades. And it just made it easy. And I said it was easy enough at that particular time do research and to sit down and think a little bit. Nowadays, that's been pretty well put to the market, and you either have to have some formal grant or you do it in your free time, which isn't available. So I think I was blessed from that standpoint, and I said I'd like to think I have some extreme talents, but unfortunately, if you really look deeply inside, I sort of made it pretty well, you know, on a moderate scheme.
No, there's no doubt that you are recognized internationally. In fact, even before I came to this place, I had heard about you, the Milwaukee group, the live endoscopy courses that were probably the first of their kind in those days.
They probably were, yeah.
On a personal note, last but not the least, you're still working. You're still an active member of our faculty.
The chief keeps me on, yes, okay.
Yeah, and people at your stage have all retired, gone, and what is that drive? What is like that energy you have in you? I mean, is this now your hobby?
It's something I guess I can't quite shake loose of at this particular point. I have some limited physical capacity, so of course I haven't been able to go to New Guinea and collect butterflies, which is something I always wanted to do. But I think I've enjoyed the fact that here at the medical college, we've had 3 directors over a period of 60 plus years. And there's been a culture that's developed, that's continued, and it's been a most enjoyable professional experience to be around people. We've added people, subtracted people. Somehow we've kept good people. We've enjoyed the experience we've been around with the interaction. And I guess at this point I'm not quite ready to cut loose, although it will happen eventually. But at least for the present time, I'm still enjoying it.
Well, thank you, Walter. And don't retire before I retire.
You'll never retire.